Polycystic ovarian syndrome and stress. This is a very important topic to our discipline. I'm Dr. Martin Rutherford. I'm a certified functional medicine practitioner, chiropractor.
Dr. Randall Gates, board certified chiropractic neurologist, as well as being a chiropractor.
For those of you who are seeing us for the first time, we have put these two disciplines together to develop some pretty consistently successful approaches to the properly selected patients who have chronic pain. And chronic pain's like what? Half the country now. I think the latest estimate I heard is it could be up to 160 million people out of 325 million people in the country. So that's what we do. We do thyroid problems, we do gut problems, we do chronic fatigue, it's not a large part of our practice, but we have people who come in who can't have children, can't carry to term, things of that nature. And in the end, so many of these chronic situations are a result of multiple vicious cycles going wrong. And frequently, a lot of these vicious cycles have been separately diagnosed and separately at least attempted to be addressed from various disciplines. And it turns out that they all kind of work together to create that person's chronic pain syndrome. And one of the ones that we see as very frequently is polycystic ovarian syndrome. And today, polycystic ovarian syndrome has a lot of connections to what we do. And we've done other talks on this, on its relativity to Hashimoto's and other conditions that we treat that are all in turn relative to, I can't lose weight, I have chronic fatigue, I got fibromyalgia, and all those types of things. So this is a big topic for us, and there's so many moving pieces, and Dr. Gates likes to do them one at a time. So polycystic ovarian syndrome and stress. And to me, it's interesting, but I'll always ask people, I'll always say, like, how come, did they tell you why, you're having these symptoms of the hirsutism and you can't lose the weight and all the symptoms you're going to go over when they come in, and they'll say, well, not really. They told me I had a cyst and that I had to take the cyst out, and they took the cyst out, and that was it. I said, did anybody tell you why you might have developed those cysts? And pretty much the answer is always no. Always no. And a lot of times there was no pathology involved, and I'll kind of broach the subject of, well, how are your stress levels? Or, delve back into some of the emotional traumas that we see that eventually work into these situations that create polycystic ovarian syndrome. And a lot of times people are kind of like it's like hard for them to kind of go, it's because I'm stressed. I'm like, well, you didn't have anything else that caused it. You didn't have another pathology, and so on and so forth. So this is something I think could be very illuminating for people, because it is something that takes me a little while to help them to understand. So stress can cause polycystic ovarian syndrome.
Can definitely be associated with exacerbations of it in our experience.
For sure.
So simple point, as Dr. Rutherford was saying, is that when you have polycystic ovarian syndrome, you have too much testosterone. You either have too much testosterone because you're insulin resistant, hence why your doctor prescribed you metformin, or you have too much testosterone because your adrenal glands genetically make too much DHEA, which turns into testosterone. You may also have a tumor on your adrenal glands that needs to be considered as well. That would be doing that. But what you also have to realize is that adrenal gland is highly connected to your nervous system. It's connected to your brain hormonally. And so when you're under increased stress, and stress is a tough term because Dr. Rutherford will commonly point out when he's talking to people in the consultation, they'll say, I'm not stressed. I'm not stressed. If you want to label it as anxiety, if you want to label it as post-traumatic stress, nervousness, a worry wart, whatever it is, if you have that personality type or you're under those types of life conditions, you need to see, is that maybe affecting why you're growing hair? Is that maybe why you haven't had a menses in 6 months? All these things need to be considered. And especially there needs to be emphasis placed on the adrenal glands, because so often in our experience, if patients are told anything, aside from the fact that they have a cyst and that they are insulin resistant and that they need to go on a diet and that they need to lose weight, pause. Basically, most of you have tried that, and we get so many comments from people around the globe who are told that by their doctors. They try to go on a diet and they can't lose weight. There are reasons for that. But even if you've been told that, you probably haven't been told that your adrenal gland is a piece of the puzzle that definitely needs to be evaluated. So that's kind of the overview. Going into the underlying, what were you going to say?
No, go ahead. Go ahead.
Okay. So going into the underlying aspects of PCOS, first of all, you need to know its diagnostic criteria. Basically, you have to have 2 out of 3 criteria of the following: either a cyst on your ovary, high levels of testosterone, which can be evidenced as, you having hirsutism, you're growing hair on your face, you're growing hair on your chest or your back, and then abnormal menstrual cycle lengths, either very short or very long in between your menses. But take note that you only have to have 2 out of the 3. So even if you've been told you don't have a cyst, but you have a mustache and you have, a menses every 3 months, that fulfills the criteria for PCOS as it's currently defined, once other things are ruled out and things of that nature. So that's important to delineate. Now, with the insulin resistance that it's so commonly talked about with PCOS patients as the cause of their high testosterone and their estrogen abnormalities, we've done another broadcast on this. I'm just bringing it up so that you can go watch them. Just know that a huge amount of that insulin resistance is tied to the gut, and that pieces of bacteria from your gut can float into the bloodstream, and that's what's causing the insulin resistance. Know that your bacteria, if you have PCOS and you're not really thin, know that probably you have this issue going on. Your bacteria is different from someone who doesn't have PCOS or like diabetes. So that needs to be considered as well. Now, once you have the insulin resistance, what happens? Is this, you with me?
You're covering what I was going to ask.
Okay.
Yeah.
So once you have the insulin resistance, and I say, are you with me? Because Dr. Rutherford critically evaluates whether you would be with me. So that's what we're making sure.
I'm here to translate it into English.
Yeah, exactly. So when you have insulin resistance, what they found is that the ovaries, rather than making a ton of estrogen, actually start making more testosterone than they should. And so that's the problematic feature. And that's the reason why your doctor is putting you on metformin. And that's why in the research articles, they've seen good results using drugs like metformin to help patients like you. Now, the new research is going into the pioglitazone medications. These are drugs like Actos or Victoza. Victoza right now is all the rage in the PCOS world because they're seeing better results combining metformin with Victoza than metformin alone to control insulin resistance and help people with PCOS lose weight. And I don't think I need to go into the mechanisms of how Victoza
on the outside chance that somebody doesn't know what metformin is. Metformin is a drug that they usually use to help control diabetes type 2.
Good point.
Okay. And so what Dr. Gates is saying is that's helping to control your blood sugar. That is causing your estrogen to turn into testosterone.
Yeah, your ovaries make more. Yeah,
so that might be a missing link for some of you there.
That was great. And so, like we talked about in other broadcasts too, just we'll hit on this. There is now what started as a small association is now a huge association between autoimmune thyroid disease, the immune system killing the thyroid, and polycystic ovarian syndrome in its association. So doctors started saying, hey, this person has PCOS and they have Hashimoto's. The research has grown to say a large percentage of patients with PCOS have autoimmune thyroid disease or Hashimoto's thyroiditis. So there's this autoimmune component. And it's thought that this inflammation in the body may actually be affecting the ovaries as well. So that's something to pay attention to and to go on to powerhealthtalk.com and search for and watch that. Now, as it pertains to stress, now let's get back to the adrenal gland and go in a little more detail. So the piece that we see not commonly tested, especially in the PCOS patients, is DHEA. It's important to check DHEA in every patient with PCOS. DHEA is an adrenal hormone, just like cortisol, just like aldosterone, which you probably have not heard of, and just like progesterone. There's a form of progesterone made from your adrenal gland. Also, adrenaline comes from the inner part of your adrenal gland. Now, when you're under stress again, your brain sends stress signals through a hormone called ACTH to the adrenals, and it starts telling the adrenals, okay, we need more stress hormones. In that course of events, though, and other hormones come from the brain and signals, you're going to increase DHEA output. What has been found is that some PCOS patients genetically have an enzymatic defect called the 1720 lyase enzyme that starts taking reserves away from cortisol and putting them into DHEA. And so it's like 2 railway tracks, and you have the little splitter that sends the train over to this side. Well, that's what happens. And so all the reserves in the adrenals go, or not all, but more go into DHEA. So a person may have very high DHEA as a female, and it's not being checked. And we see this as especially important in any PCOS patient who's thin, because lots of times their insulin resistance is not as bad as someone who is overweight. That's not always. And then also any patient who has PCOS who maybe is battling their weight and they can't lose weight, we found that this is a really important avenue to consider, because your stress levels may actually be driving your high levels of testosterone, further promoting your endocrine imbalance. And then that's causing a lot of the symptoms of the PCOS. And a lot of these patients, you're told, there's not much we can do for you. You have to go on birth control. Femara is the new drug that it's kind of all the craze. Because basically, if your testosterone's high, the medical view is put you on metformin. Hopefully that brings your testosterone down. That doesn't work. We're going to put you on birth control and give you lots of estrogen or progesterone to balance out these female hormones. Now, a lot of women don't want to be reliant on taking these medications. So that's why we do these broadcasts, because we want to illuminate to you, well, if your hormones are like this, it's really about a ratio. So maybe you just need to drop the testosterone. And looking at your stress levels is the next thing to really survey, because so many people don't even realize how stressed they are. And you see this all the time in the consultations. I don't know if you want to offer your perspective on that.
No, I mean, I can use my own personal example. Not that I have PCOS,
Right.
but when I first got into this, I had developed fibromyalgia and peripheropathy and chronic fatigue and a number of things. And I had first started out, I was fortunate enough to first start out with understanding through some articles and through speaking to a doctor who did what Dr. Gates does about these chronic stress levels. And he was talking to me about, and I said, well, yeah, I think I'm handling the stress I'm going through pretty well. He says, no, it's not that. He says, you've been through emotional trauma. I was dealing with, well, I won't tell you what I was dealing with, but I was dealing with something that was, when I usually mention it to people, they go, oh my God, that's stressful to go through that for 7 or 8 years. But you could have had trauma like physical or verbal or sexual abuse, or you could be through some sort of a very difficult challenge, a difficult divorce. Maybe you had a rough relationship with your parents or stuff like that. And these emotional traumas tend to wire your brain so that it keeps putting out these stress hormones. And so people will come in, and so these stress hormones can do a lot of things. They can cause short-term memory loss. They can cause you to not be able to sleep. You wake up, you can't go back to sleep. They can cause chronic sinus infections, chronic lung infections. Most people are commonly understand they can cause acid indigestion, ulcers. They can damage your gut with stress hormones. They can do what Dr. Gates is talking about with your adrenal glands. So my experience is when people come in and they're experiencing that that phenomenon. I think it's that biochemical, neurochemical situation. It's something that I have to talk to people about and say, okay, you seem to have some signs as I'm sitting here of this particular phenomena occurring. And some people say, I'm not stressed. Other people will just start shaking their head right away. And I'll walk through this. And the significance is you have to take that pattern, and there's more to it than what I just got done talking about. And you kind of have to take that pattern out and take all of those symptoms, including, I haven't been able to carry a baby. I haven't been able to get pregnant. I've tried, I've been pregnant 3 times. I haven't been able to carry to term, those types of things. You have to take all those symptoms out, because these are things that people come in for. And you can't even start, really, in my mind, you can't even start to properly diagnose that person to get them through their situation until you take that chronic stress mechanism and place all of the things that could be causing up against their myriad of symptoms. And polycystic ovarian syndrome, a lot of people don't even come in here for that. They come in here with that, but they come in here, they're depressed and they can't lose weight. And some of them come in here because they can't carry to term, or they can't conceive, and they've heard that some of our patients were able to get better and things like that. But nobody makes the connection to the PCOS, and 0 people make the connection to the stress. So I was going to ask Dr. Gates, well, you know, where's the stress pattern? Where's the stress in all this? And he started to get to it. And I think the question I'm going to ask if I'm sitting out there is, okay, so if I have that, I'm already taking Xanax or I'm taking Prozac, or is that what I do? Or like, what do I do for this?
That's a really great question, because
I hate to put you on a spot.
No, I'm with you. So
because if I'm watching polycystic ovarian syndrome and stress, I'm like, okay, what do I do for this?
In our experience, and this is what the literature supports, is that when people are
I just
under
put them on
chronic stress or they have anxiety, especially, there is a major imbalance between the fear center in the brain and the memory center. They're like a ham sandwich. Problem is that when the fear center gets overactivated, like the American lifestyle promotes, frankly. Side note, we just had our first patient who doesn't have a smartphone. And she doesn't have a smartphone because she doesn't want to be interrupted. She wants to stay focused. And I said, wow, major props to you, because all of us on the bus, so to speak, on our smartphones, we're always stressed out. You wake up late, right? And then you got to get the kids ready, or you got to get yourself ready, and you're rushing out the door and you don't eat breakfast, or then you're eating breakfast in your car as you're driving. And then you go by Starbucks because you want to get your caffeine, and then you crash after lunch, so you get more caffeine. You come home and then you can't fall asleep and you can't stay asleep and you wake up tired again. Sound like you? Because that's most people. I know I've been on that hamster wheel, so to speak. So when we're in that state, the fear center is overactivated. Then that causes the adrenal glands to make a lot of cortisol, which actually kills your memory area and your frontal lobes over here. Your memory area and your frontal lobes are trying to keep your fear area beaten down. It's like a tug of war. Problem is that this fear area, I feel largely because of our lifestyle and events going on in this country, cause this fear area to light up. And now we have this like evil dictator that's taken over. That's then causing your hormones to change and driving these stress responses. Really, the solution is to get your frontal lobe strong and to build new brain cells in your memory area. There are a number of ways to do that. Some pharmaceuticals do that. Other pharmaceuticals shut down this fear area, but it's more of a temporary fix, and those drugs tend to be addicting. Or what we do is we do brain rehab, where we actually go in and we strengthen the frontal lobes, specifically in the part of the frontal lobes that are weak, to get the frontal lobes better able to shut down the fear area. When we do that, patients usually notice a difference. Then we use supplements to build new brain cells with the intent of that in the memory area, and also to calm down adrenal firing patterns and things of that nature. That's where we've had a lot of success in this model.
It can be done without drugs.
It can be done without drugs.
This is why Xanax and Prozac and those are, I think they're among the top 5 drugs.
Yeah, they're very common, yeah. I can't remember
or higher than that in this country, because this is a big problem. And this stress is at the very least driving your PCOS. And if you have any of those issues, and you have blood sugar that won't come down, or you can't conceive, or you can't hold the term, or you're overweight and you can't lose the weight, and you have polycystic ovarian syndrome, and it was just kind of got blown by. It was like, okay, you have cysts on your ovaries, so we need to give you this or take it out or something like that. You know, that might not be, it's a solution. Don't get me wrong. We're not anti-medicine, but it might not be the best long-term solution. And it might not be successful. Those of you who have these PCOS problems and you're not connecting the stress to it directly. You know, some people say, yeah, I get that I'm stressed and that's maybe why I can't have a child, but you don't really get why. Like, what is the actual, there's actually a functional reason for it. And understand that those drugs are trying to address those functional reasons, but in a way that interferes with the chemistry or shuts it down or alters it or something like that permanently in a lot of cases. And there is a better way. That wasn't the whole point of this thing, but it was to let you know that stress is at the very least, a perpetuating factor of
in our
that
experience, yeah.
Yeah, and I think it's something that you really, really have to be aware of.
I think that pretty well says it. Yeah. So if you have any other topic ideas you want us to talk about, so say you're a PCOS patient who wants to talk about X, Y, or Z, send it to us. You can go to powerhealthtalk.com. We have a comment section. Again, our other videos are on there. You just have to search for them in the search tab. You can search about Hashimoto's or PCOS and Hashimoto's. Everything is there, and all the references are below the videos on powerhealthtalk.com. So I think that pretty well says it. We'll see you next week, and thank you for watching.